But now many of the surgeons prefer early surgery, even in case of acute cholecystitis, and it has many strong reasons for this policy. And when the stone is in the bile duct, that is called a doculichthysis, the treatment is extraction of the bile duct stone, preferably by endoscopic maneuver, that is ERCP, and then this is followed by cholecystectomy, that is removal of the gallbladder. Or if it fails, that ERCP cannot clear the bile duct stone, then you have to do it surgically. It is called a doculichthytomy and cholecystectomy. Now, is there any role of medical therapy for gallstone disease? Many of the patients ask frequently. We have stones, do not need to undergo surgery, treat us with medicines. So bile dissolution, that is gallstone dissolution agents. But these have unproven or doubtful efficacy. These are not evidence-based. And if it works, even if it works, there is every chance of recurrence. The stone will certainly recur because the gallbladder is diseased. It will again accumulate stones in it. So these agents have unproven or doubtful efficacy. These are not evidence-based, and there is every chance of recurrence. So these cannot be recommended in gallstone disease. Now, the renal stone, again a common entity in acute abdomen patients. So these patients are middle-aged patients, average between 30 to 50 years, and a slightly male preponderance. Again, renal stone patient may be asymptomatic, particularly when the stone is embedded in the solid substance that is not in the collecting system, in the parenchyma or cortex. This patient remains asymptomatic. Or the patient may present with a dull loin pain or flank pain when the stone is in the minor or major calyx system. And the dramatic presentation of the ureteric colic, when the stone impacted at the PUJ junction or traveling down the ureter. The dreadful agony of ureteric colic occurs. Pain starts in the loin and radiates down to the groin. It is of great severity, and the patient is typically restless, unable to lie in the bed or sit. He or she just tosses in the bed or in the chair. This is one of the most dramatic presentations in acute abdomen patient. The patient may also have hematuria, which may be macroscopic or macroscopic. So what investigation can be done? The simple thing is to test the urine for the presence of blood. This is very helpful. It is said that if the urine is free of blood, that unlikely that it is the case of renal or ureteric colic. So in most of the cases, you will get RBC in the urine. That is microscopic or maybe macroscopic. And if you do the plain X-ray of the kidney ureter bladder region, you can detect the stone in 90% of cases. But maybe due to lack of preparation, it may miss in some cases. And then the intravenous urogram. It will demonstrate the exact anatomy of the renal system, the presence of any complication like hydronephrosis, and also it will show the excreted function of the kidney. but the investigation of choice nowadays is non-contrast CT scan. It is replacing intravenous ureter. This is more sensitive and quickly done, and also it can diagnose the alternative pathology. So what will be treatment for these small stones? If the stone is small, if it is less than 5 millimeter, and if it is in the lower ureter, possibility that it will expel spontaneously. And this patient can be treated expectantly. So the patient needs strong analgesics, and NSAID like diclofenac or ketorolac can be given for pain relief. And these patients have to be observed for the further onset of pain, or the pain is recurring, and the patient is getting fever, and check the white cell count. Is the white cell is rising? That is indicating infection of the urinary system. And also look at the estimated GFR, whether the GFR is declining or not. So when you put a patient on expectant treatment, you have to look for this, whether the pain is subsiding or not, whether the patient is becoming febrile, whether there is rising of the WBC count, or whether there is declining of the eGFR. So if there is frequent episode of pain and there are signs of infection, obstruction, or significant decline in the renal function, then in these cases, you have to intervene. You have to refer the patient to the appropriate center. And what are the options for this stone removal? There are non-invasive and minimally invasive options, as well as the open surgical options. So the extracorporeal shock absorption or the percutaneous nephrectomy, and there is ureteroscopic removal of the stone. And when these facilities are not available or have failed, and then open surgical removal can be considered. You know, when the patient wants to form a stone, he or she can again form stone. That is the recurrent stone former. So to prevent recurrent stone forming, there is place of medical therapy. The goal is to prevent further formation of new stones or the further growth of the existing stones. The treatment may have to be continued for lifelong. In general, a high fluid intake is advised. Plenty of water has to be taken to prevent the supersaturation of the urine. The aim is to produce at least 2.5 liters of urine in 24 hours. And dietary excess of certain things needs to be eliminated. And if there is metabolic cause like hypercalcemia or other thing, this has to be treated accordingly. Now this is a table where you can briefly compare these common three conditions, that is appendicitis and cholecystitis and renal colic. You see the site, maybe parambolic. This appendicitis starts in the perimetric region, then chiefly right iliac fossa. In the acute cholecystitis, the pain is first in the right subcostal or epicostum, then may radiate to the right scapular lower angle, and in the case of renal colic, groin, and then radiating from groin to groin, and then the nature of the pain. And if you examine, you get tenderness in the right iliac fossa in case of appendicitis, in the right upper quadrant in case of cholecystitis, and you get tenderness in the lumbar region or in the left iliac or right iliac fossa in case of renal colic. And you may get McBurney's point tenderness or Robson signs positive in case of acute appendicitis, Murphy sign positive in case of acute cholecystitis. And among the laboratory findings, neutrophilic cholecystitis is found in the acute appendicitis and acute cholecystitis. And in renal colic, you get the RBC in the urine routine examination. And among the imaging, the ultrasonogram will show the thickening of the appendix wall, and there may be collection in case of acute appendicitis. And you get the gallbladder stone as a echogenic structure with a distended edematous wall in case of acute cholecystitis. And the X-ray cave will show the radioactive stone at the renal pelvis or along the course of the ureter in case of renal colic. So these acute appendicitis patients, you know that these are not like other common patients that you used to see in your regular practice. These patients need extra care, extra bit of attention, and a bit more time. And our goal is to detect these patients, that is, any serious intra-abdominal pathology. We need early diagnosis and timely treatment, timely intervention, and this will ensure a smooth recovery, and we can prevent the unwanted complications. So the timely referral to appropriate place or person will enable timely intervention, and this will prevent both mortality and mortality. And the GP's role is even more important in this case situation. So when people may have a limited access to the hospital or a specialist for different reasons. So that is it. That is our session today. We have discussed about the approach to the acute abdomen, and also have discussed about the common entity in the acute abdomen surgical practice, that is acute appendicitis, Gallstone disease, and Gallstone disease. I hope you will find it useful in your practical life, and you'll see these patients, try to apply this to detect whose patients need immediate hospitalization and may need urgent surgery, or which patients can be treated by yourself. That is, those are not really acute abdomen, but mimicking acute abdomen. Of course, those patients, those mimicking acute abdomen that has other serious problems like the myocardial infarction, dengue fever, or something like this. So thank you all. I think you can ask me a few questions or comment if you like.
হ্যালো
হ্যালো,
জি আসসালামু আলাইকুম স্যার।
কার কি কোনো কমেন্ট বা আছে, কোনো কোশ্চেন আছে?
স্যার স্টুডেন্টদের মনে হয় না কোনো কোয়েশ্চেন আছে, অনেকেই লিভ করেছে।
আচ্ছা আচ্ছা, আমরা কি ক্লোজ করে দেবো?
জি স্যার।
আচ্ছা, ধন্যবাদ।
জি স্যার, আসসালামু আলাইকুম। আর স্যার ওই যে পাওয়ার মানে প্রেজেন্টেশনটা স্যার আমাকে একটু যদি কষ্ট করে মেইল করে দিতেন।
এইটা পাবেনটা?
হ্যাঁ হ্যাঁ স্যার, পাওয়ার পয়েন্ট।
আচ্ছা, আপনার মেইল অ্যাড্রেস কোনটা জানো?
আমি স্যার আপনাকে এসএমএস করে দিচ্ছি।
আচ্ছা আচ্ছা, পাঠিয়ে দিচ্ছি, ঠিক আছে।
আসসালামু আলাইকুম।
ওয়ালাইকুম আসসালাম।